everybody. So, just to tell you who I am. So I'm a general adult psychiatrist. I work in Camden in a community mental health team called a core team. It's a new sort of team, which is very integrated with general practitioners. And in fact, we work with only one PCN and 4 general practitioners. So we're in quite a fortunate position, and it allows us really to sort of meet with GPs to understand, what their issues are, what our shared issues are, and sometimes, what the problems are. I imagine all of you have been frustrated with the sort of communication you may or may not receive from mental health teams at different times. And communication is obviously a big part of the sort of working together issue. I'm going to talk about SMI and physical health with some focus on diabetes, but I don't really apologize for this not being just about diabetes, because actually it's really about the necessity to take a holistic approach in relation to people with SMI, as with everybody, but particularly people with SMI who may struggle in all sorts of ways with their physical health and their mental health. So something I hope all of you are already familiar with, that patients with schizophrenia and other psychoses die prematurely, and they tend to die 15 to 20 years younger than the general population. And this obviously has been a focus of a lot of attention and a lot of work over the last few years, and nevertheless, it's a mortality gap which isn't narrowing, it's in fact widening. And people with SMI die of the big killers. So this is Islington. Sorry, I couldn't find the more recent slide or data, but they particularly die of cardiovascular disease and respiratory illnesses linked to smoking, cancer, and liver disease. So there's a much higher burden of illness in people with SMI. So particularly, I'm going to point out the obesity, diabetes, and smoking, which are especially relevant to this talk. And not only do people with SMI have a higher likelihood of developing chronic conditions, they develop them at an earlier age. So SMI, in total, for example, the rate of diabetes is between 2 and 3 times the general population, but for younger people between the age of 15 and 34, it's nearly 4 times. So as I said, the mortality gap, despite QOF, despite the additional focus within mental health service on this as an issue, is something which is the business of mental health services and not just general practice. The mortality gap is widening. So this is a measure of premature mortality. And you can see that even from 2015 to 2017 to 2018, there's been about a 4 to 5% widening of the premature mortality gap. And that is caused by these. So this is mortality from liver disease, respiratory, cardiovascular disease, and cancer. You can see that there's been a trend of a widening inequality over the last 12 years. So just to recap, really, so people with schizophrenia who develop cancer, they're 3 times more likely to die than those in the general population with cancer. People with severe mental illness are twice as likely to die from heart disease as the general population. And so depending on which SMI population you look at, the smoking prevalence is anywhere from 50% up to 85%, actually, compared with, this is a slightly old slide, about 13.5%, 14%, I guess, in the general population. And that compares to about 35% in the most deprived population. So deprivation isn't the only explanation. There's something above and beyond that impacts smoking prevalence for people with SMI. Not just more likely to smoke, they smoke more heavily. I remember reading somewhere many years ago that people with mental illness smoke over 40% of the cigarettes smoked in the UK. And prevalence of type 2 diabetes is 2 to 3 times higher in schizophrenia than the general population. Not only are they more likely to have a chronic condition, they're more likely to have several chronic conditions, and that inequality widens with the number of conditions. So the prevalence of 2 or more is 1.8 times the general population, and then the prevalence of 4 or more is twice the general population. So there's a clustering of conditions and risk factors. I'm afraid the numbers are slightly the wrong way around, but so obesity. This was a sample of about 60,000. This was taken from primary care data, and there were matched cases, about 60,000 people with SMI and about 240,000 people without SMI. So there was an excess of obesity, alcohol misuse, a big excess of drug misuse in the SMI group. So what's the background to SMI and diabetes? All sorts of factors. And it's sort of obvious in some ways. So antipsychotic medication is both obesogenic and diabetogenic. And then SMI more likely to experience deprivation. Lifestyle factors, poor diet, much lower activity levels, much more likely to be unemployed and at home, much more likely to be obese. And as I said, there's a massive smoking prevalence amongst people with severe mental illness, and diabetes is one of the major causes of death in that group. So in 2018, the National Diabetes Audit focused on SMI and diabetes, I think for the first time, and they looked at over 60,000 people with type 2 diabetes and SMI. Interestingly, type 1 diabetes was, there was no excess in SMI, as you'd expect, but not only did they confirm that people with SMI are at least twice more likely to develop type 2 diabetes, but they develop it earlier. And when looked at the interaction with deprivation, in the most deprived quintile, 35% of people with SMI had type 2 diabetes compared to just 8% in that population. And then the tests, the eight tests for diabetes, the surveillance, people with SMI are less likely to have all 8 tests, and in particular, foot surveillance and urine albumin. I've sort of talked about that, but so they're more likely to be unemployed, have poor accommodation, be on benefits. Deprived populations are more likely to have a higher prevalence of SMI. SMI people in deprived areas have higher rates of physical health conditions. I've talked about smoking, but just one thing I wanted to also, we did a local audit of rehab ward patients, psychiatric rehab ward patients. There were 4 rehab wards in our trust, and we, of those who agreed to be interviewed, 83% smoked, and 17% had a diagnosis of COPD. And I say those who agreed to be interviewed because there were some who were on their way out for a fag saying, oh, no, I haven't got time now, cough, splutter. So 83% is probably an underestimate. The other thing about smoking, which is something that psychiatrists have to be very careful about, is that tobacco smoking induces liver enzymes which metabolize antipsychotics. So often smokers require a relatively higher dose of antipsychotic to achieve an equivalent treatment effect. This is particularly the case with clozapine, and one of the sort of risks is that people then stop smoking suddenly, as you want them to do, and their plasma levels of antipsychotic go very high. In clozapine, that can be quite risky in terms of a seizure or postural hypertension or agranulocytosis, etc. So improving SMI and care and outcomes. Okay, so this is difficult. And, but I was talking to somebody before we came in, and I think it was, might have been Derek actually. Somebody said to me that we're not allowed to use the word integration anymore. And I felt that's something, it's probably a word that we can use again. Like maybe 2 years ago, we'd all developed integration fatigue, but the sort of atomization, the alienation of the the pandemic has probably renewed our appetite to be a bit more integrated. So a lot of the initiatives that we've been involved in over the last few years are all about trying to bring general practice and mental health services closer together to look at this, to take a shared responsibility, and to move mental health services towards adopting core principles that involve population health and prevention. So confession, when I started as a psychiatrist in the early 90s, and I remember there was a sort of prevailing attitude that patients would be admitted to hospital and they might have some physical health condition. They can see their GP when they're discharged. And there was a real sort of mind-body, dualistic detachment, really, within psychiatry, based on all sorts of things. I think it was a time, and also people weren't confident in addressing these things, and perhaps had been in psychiatry for a long time and relied on their junior doctors too much to think about issues of physical health. But increasingly we're moving towards encouraging mental health staff and psychiatrists to take more responsibility and take a collaborative approach with other professionals involved in that person's care. I'm going to mention some focused interventions to support people with SMI to access screening and treatment. This is a big issue for a lot of people with more severe mental illnesses, that they just have difficulty articulating the needs, attending appointments on time, opening letters, charging their phone to receive the text message, all of those sort of things which require basic organization. One of the most common features of psychosis is just a sort of basic disorganization, whether that's in terms of the chaos that often surrounds people who have severe symptoms, or a sort of intrinsic, fundamental psychological disorganization. So this is just very quickly. So in around 2017 to 2018, we got a little bit of money to launch a project involving mental health nurses doing a bit of training in physical health care, particularly in trying to help people with schizophrenia attend their screening, their QOF screening tests. And we distributed them around GP practices in Islington. It was spread quite thin, but their remit was to focus on those people who tended not to come, the exceptions, the hard-to-reach people, people who tend to be in their house a lot, not attend appointments. And I included the HbA1c slide, but across the board there was a sort of steady improvement in patients attending for their screening tests. And I think that this chimes with research that was done, I guess, in the early noughties, looking at if you augment standard care with some nursing or some mental health nursing, people with some knowledge and experience and expertise in communicating with people with severe mental illness and knowing how to cope with the particular problems faced by that group, then that can have a big impact on the access to care. I just wanted to mention antipsychotic medication. It obviously causes weight gain, metabolic syndrome, but also it's quite sedating. It causes tiredness. It's harder for people to live more active lives. Not all antipsychotics are equal, so clozapine and olanzapine are the worst. And then you have drugs like aripiprazole or amisulpride that are much less associated with weight gain and metabolic changes. And in fact, actually, sometimes adding a low dose of aripiprazole, if somebody is already established on a more sort of obesogenic antipsychotic, adding a low dose of aripiprazole can sometimes actually limit the trend towards weight gain. So what do we do? Well, review the dose, try and get somebody on the lowest effective dose. You have to do this carefully. And also when switching to particularly switching to something like aripiprazole, which is a competitive agonist for dopamine, do it gradually. So do lots of slow cross-tapering and never, ever, ever stop one and start the next medication, because often that can precipitate a very rapid rebound psychosis. Metformin is quite well established, but very, very much underused. So I recently did a sort of a very, very informal email survey of colleagues around the trust whether they were using metformin for their patients with antipsychotic-induced weight gain, and almost nobody was, which was disappointing. And then maybe in the future, GLP-1 receptor agonists could be useful in treating antipsychotic associated weight gain, perhaps particularly for people who are not very good at taking oral medications reliably. But what I wanted to focus a bit on is a project that we've been working on for the last 2 or 3 years, Primrose A. So this is, you know, I included the BMJ Awards, highly commended banner. So this was something that we ran in the early months of 2020. So this was so right at the beginning of the pandemic, which was a little bit awkward because this was as a behavioural change intervention delivered in primary care settings by primary care staff, primary care nurses and healthcare assistants. And the aim was to have a series of 30-minute sessions with a nurse or a healthcare assistant over a 6-month period, so you know, every fortnight or so, to support people towards making 1 or 2 changes which would reduce their risk factors for cardiovascular disease. This was based on a recent research, Primrose trial, which was published in Lancet Psychiatry in 2018. And we added a sort of a non-evidence-based innovation. We added peer coaching to that. And I'll explain more about that in a little while. But so the person would also be offered 4 one-hour peer coaching sessions in addition to the nursing sessions. So one of the interesting aspects of the original Primrose study, so what they found is that they focused on behavioural change, and that was good, but they slightly shifted the focus away from prescribing statins, and so that was something that we learned from. But one interesting finding is that the costs were favourable. So the psychiatric inpatient costs were much lower for the people who'd received this, you know, primary care generic intervention, not focused on mental health per se. And there's something very attractive about this. I started talking about integration. This seemed to be an opportunity to deliver something which is really integrative, in that the focus wasn't on somebody's mental health or taking their antipsychotics, or it was on providing support, helping them develop problem-solving skills, setting goals and following them, coping with setbacks. And it seemed to have a generalized effect on their mental health. In any case, the difference in their psychiatric inpatient costs alone were £956 on average for the control group, and £157 on average for the Primrose group. We developed and adapted a sort of a manual. So it was a manual-based intervention, but this is basically the structure of what was delivered. So the patient and the nurse, or the patient and the healthcare assistant, would decide on one behavioural change goal, and then take steps towards that. So whether that's, you know, manage pre-diabetes or stop smoking, and then they would meet for 30 minutes every couple of weeks to assess progress and think about next steps. What doesn't work well? Telling people what to do, or providing information only. More effective is a sort of motivational interviewing approach. So focus on change talk. So what the patient offers up in terms of their ideas or their aims, or what might be related to positive change in reducing their cardiovascular risks. And soften sustained talk. So sustained talk is that which is about status quo, reasons why nothing can change, you know, pessimism, or you know, why they like cigarettes so much, how they could never stop. So so it involves a sort of supportive, empathic conversation in which objectives can be developed jointly. So involve support of others. So if the person has a carer or partner or a mental health support worker, encourage them to bring them along to the meetings. Create an action plan. Provide positive feedback, and help people cope with setbacks, because it never goes smoothly. And eventually form habits. So this was a fairly straightforward training package. It was originally a 2-day training package. Now we do it pretty much in a day with some training videos and other materials as well. So it's quite straightforward in terms of training. I just wanted to talk about peer coaches. So this is a sort of increasing workforce in mental health. But Primrose was the first time I'd actually worked alongside peer coaches. So they're obviously people with lived experience of mental health issues. And their meetings with the patients were much less structured. So they weren't trying to be, little nurses. They had their own thing which they bring to meetings. And they've just helped people ground the process and the goal setting in their own experience. They sort of supported them with attending appointments and reminded them if that was needed. Just assurance and encouragement and sort of standing with them. And just our aim was to sort of enhance or to augment that finding in the original Primrose study around the sort of psychological benefits of Primrose. It wasn't particularly evidence-based, but just seemed intuitively that this is something that we could adapt. So, it being the lockdown, rather disappointing. I'm not going to present you with some sort of amazing graphs of HbA1cs coming down and weights plummeting, because actually we couldn't do follow-up blood tests because people weren't going to surgery. We couldn't have that. GPs didn't want patients coming in for elective tests. So we had to rely on some other measures which are obviously not quite as exciting in some ways, but one of the things we did was we used a dialogue score. I'm not sure if you may have heard of this. This is a quality of life and functioning score across a whole range of different quality of life, so things like how satisfied are you with your housing, your friendships, your work, your leisure activities, your medical care, your medication, etc. And we found that there were improvements. So patients liked the intervention, basically, and that they rated various aspects of their quality of life had improved over the course of the intervention. Most of the sessions were actually conducted on the phone, which we were really worried about, but we were just about to recruit the first patients when the first lockdown happened, and we can't stop now. And actually, it turned out to be a really good finding. I'm sure lots of you have worked on the telephone over the last couple of years as well. But for some people with SMI, they just would never have attended a face-to-face appointment, and actually they were quite happy to chat on the phone. Interestingly, that lot of patients I work with at the beginning of lockdown, I said, well, how does it feel being alone a lot? I said, well, doctor, I spend most of my time alone. I feel more normal now because everybody else is doing the same thing as me. So actually, it was quite a sort of fortuitous finding that it seemed to be quite all right to do this on the phone. We've gone back to a face-to-face model. These were the goals that people chose. It's sort of quite obvious, really. So improved diet, exercise, weight loss, smoking cessation, being social. And again, this is subjective. We had to rate something. So this was a subjective measure of how people felt they'd done in achieving their goals. And most people thought they'd done quite well. We interviewed patients and nurses and GP practice afterwards, and this is what they felt. This is what they felt was good about the project. So the GPs felt that there were improved patient outcomes, that it was cost-effective, that crucially it didn't add to the workload. It seemed to relieve the workload. So, and it was a simple intervention. Nurses valued the longer contact, they valued the clarity of the definition and the training, and they felt they sort of now knew what to do. And the patients just valued the support, the regular contact, the longer contact, learning, there's new skills learned around goal setting, and also the familiarity of it being in the local GP practice and not having to go back to their mental health service or that sort of thing. So it was less stigmatizing. I mean, one of the things that I was initially quite attracted to was this sort of, finding that it seemed to have had a positive impact on somebody's risk of a psychiatric admission in the year after receiving the intervention. I mean, not just because that offered a saving, but actually the saving could then potentially allow Mental Health Trust to reinvest in this sort of preventative activity. And the next steps, well, so this is now underway. We're in collaboration with the UCL partners and their proactive care frameworks. We've brought the two models together, so bringing together a sort of risk stratification tool and best practice guidelines and the Primrose intervention, and received a national grant to actually look at how to implement that, not just in London, but in 3 regions and across North Central London. So that's quite interesting. And so based on the pilot that I just showed you was quite a small pilot. It was just Kentish Town GPs, but now actually we're I can't remember, but we're actually in GP practices across Camden. And the learning from it contributed to the formation of the new core teams. So our workforce in core teams, it's a sort of blended team. We've got peer coaches on the staff, so to speak, as well as voluntary sector workers and social prescribers. So a lot of the learning that we gained from running this sort of integrated, holistic intervention has become our basic model of care in many ways. And that's it.